Hello everyone, today we'll be talking about diuretics in renal pharmacology. Diuretics are the drugs that promote the excretion of sodium and water in urine. So, when they cause excretion of sodium and water, they help to reduce the plasma volume. This helps in reducing the blood pressure and also any excess fluid in case of any edematous states. Okay. So before we get to know what is the classification of the diuretics and where they act, we should first know the normal physiology that occurs at the level of nephron. So in the nephron we have the glomerulus, the PCT, the loop of Henle, the DCT and the collecting duct. At the level of PCT, 2/3 of the filtered NaCl and water is reabsorbed. Since equal amounts of NaCl and water is reabsorbed at this level, the fluid that leaves the PCT is said to be isoosmotic. Equal amounts of potassium and urea are reabsorbed at this level. 70% of filtered calcium and 80% of phosphates and bicarbonates are reabsorbed. PCT is the only level at the nephron where glucose reabsorption occurs. 100% of filtered glucose and amino acids are reabsorbed at this level. In the loop of Henle, the thin descending limb is impermeable to sodium and urea, but water reabsorption occurs at the thin descending limb. 15% of filtered water is reabsorbed at this level. At the thick ascending limb of loop of Henle, sodium potassium 2Cl co-transporter helps in reabsorption of these electrolytes. Also, calcium and magnesium reabsorption occurs at this level. Loop diuretics inhibit the sodium potassium chloride co-transporter. At the level of the early distal convoluted tubule, which is impermeable to water, NaCl reabsorption occurs through the NaCl co-transporter, which is inhibited by thiazides. 9% of filtered calcium is reabsorbed at this level. PTH also acts at the level of the early DCT to increase calcium reabsorption in the blood. In the late DCT and the collecting tubules, two types of cells are seen. They are the principal cells and the intercalated cells. The principal cells are acted upon by aldosterone so as to increase the excretion of potassium and increase sodium reabsorption. They are also acted upon by ADH, which causes increased water reabsorption in the principal cells. The intercalated cells play an important part in acid-base physiology. Here, H plus K plus antipode is present, which is responsible for acid-base physiology. So, coming to the classification of the diuretics, we have carbonic anhydrase inhibitors like acetazolamide. We have osmotic agents like mannitol. They act primarily at the PCT and the loop of Henle, but they can act throughout the tubule. Carbonic anhydrase inhibitors act at the level of PCT. Loop diuretics act at the level of the thick ascending limb of loop of Henle. Thiazides act at the level of early distal convoluted tubule. And potassium sparing diuretics act at the level of the collecting tubules and the late distal convoluted tubules. So coming on to the first one, that is carbonic anhydrase, which inhibits the resorption of bicarbonates in the PCT. In the PCT, we have the sodium hydrogen antiport at the luminal membrane of the tubular cells, which causes resorption of sodium. Remember that 2/3 of filtered NaCl is reabsorbed at the level of PCT. As H+ is exchanged to enter the lumen, it binds with filtered bicarbonate to form carbonic acid, and this carbonic acid is dehydrated in the presence of enzyme carbonic anhydrase to form CO2 and H2O, which is reabsorbed into the cell to form carbonic acid with the help of the enzyme carbonic anhydrase. This carbonic acid is then broken to form bicarbonate and hydrogen, which is then again excreted to bind with the filtered bicarbonate. The bicarbonate, on the other hand, is reabsorbed into the blood, and sodium is reabsorbed by the help of Na+K+ ATPase pump. So if carbonic anhydrase blocks this step, it results in increased bicarbonate getting excreted in the urine. This affects the function of Na+H+ antiport, which results in increased sodium entering into the urine. However, it is a weak diuretic because further down the line, this sodium is reabsorbed inside the thick ascending limb of loop of Henle and at the level of the DCT and at the level of the collecting ducts. The increased amount of bicarbonate excreted in the urine can result in metabolic acidosis. So carbonic anhydrase inhibitors like acetazolamide cause self-limited bicarbonate diuresis and decrease the total body bicarbonate stores. They are useful in glaucoma and alkalinization of urine. They are also useful in metabolic alkalosis and altitude sickness or mountain sickness and in pseudotumor cerebri. They can cause bicarbonaturia and acidosis. Hypokalemia. This occurs because the increased sodium inside the lumen will then be exchanged with potassium at the level of collecting ducts. Paresthesia and renal stones may occur, and it may also cause sulfonamide hypersensitivity. Coming to osmotic diuretics, which can involve the entire tubule, but the main action occurs at the level of PCT and the loop of Henle. How they act is that they increase the solute concentration in the lumen. So if these are the tubular cells and this is the lumen, this is the blood. Because of the increased concentration of the solutes in the lumen, based on the law of osmosis, more and more water will come to the area where there are more solutes, and there will be less water where there are less solutes, right? So what it does is that it pulls the fluid into the lumen because it causes increased osmolarity inside the lumen. So if we take excess of this, what it does is that is bringing the intercellular fluid into the extracellular compartment. and so there can be pulmonary edema in severe cases, and can also cause dehydration because it is causing movement of water via osmotic principles. So they increase the osmolarity of the tubular fluid and are useful in decreasing the intraocular tension and intracerebral pressure. They are useful in oliguric states and can cause pulmonary edema and dehydration. They should not be given in heart failure or any active intracranial bleed, or chronic edema or anuria. Loop diuretics inhibit the sodium potassium 2Cl co-transporter at the level of thick ascending limb of loop of Henle. This co-transporter helps in reabsorption of these electrolytes into the blood. Sodium is reabsorbed by the Na plus K plus ATPase. But what is this ATPase pump doing? It causes K plus to enter the cell. So when K plus is being reabsorbed here, it causes excess K plus inside the cell, and this exits the cell via the luminal membrane. This causes a positive potential at the luminal membrane, which helps in developing a gradient which causes magnesium and calcium and other cationic ions to get reabsorbed via the paracellular pathway. K plus and Cl minus are reabsorbed via diffusion down the electrochemical gradient. So if this is blocked, there is no positive potential at the luminal membrane, which prevents the reabsorption of calcium and magnesium. This causes them to be excreted in the urine, resulting in hypomagnesemia and hypocalcemia. Also, because sodium and potassium are not being reabsorbed, it will cause hypokalemia. And because sodium in the lumen will cause increased water in the lumen, so they will be excreted in the urine. So loop diuretics inhibit the co-transport system at the thick ascending limb of loop of Henle and abolish the hypertonicity of the medulla because they affect the loop of Henle, which is responsible for the countercurrent system, which is responsible for concentration of urine. So they are useful in acute pulmonary edema, heart failure, hypertension, and in anion overdose, and also in hypercalcemic states, because you remember they are blocking the calcium reabsorption at the level of thick ascending limb. They can cause sulfonamide hypersensitivity, hypokalemia and alkalosis, hypocalcemia, hypomagnesemia, and hyperuricemia and ototoxicity, especially ithacranic acid. Hence, they should not be given with aminoglycosides because it causes enhanced ototoxicity. Chronic loop diuretic administration with lithium can cause decreased clearance of lithium, resulting in toxicity. And because of the electrolyte disturbances caused by loop diuretics, this should not be given with digoxin also because it can cause digoxin toxicity. Thiazides act at the level of early distal tubule where they inhibit sodium chloride co-transporter. Thiazide examples include chlorothalidone and hydrochlorothiazide, and thiazide related diuretics, that is chlorothalidone, indapamide and metolazone. At the level of the early distal tubule, Na plus and Cl minus co-transporter helps in the reabsorption of these electrolytes. The Na plus enters the blood via the Na plus K plus ATPase. K plus channel helps in K plus reabsorption, and chloride is reabsorbed by its own channel. But if this co-transporter is blocked, there is decreased Na plus entering the cell, and so the Na plus Ca2 plus or sodium calcium exchanger helps in Na plus entry into the cell associated with calcium reabsorption. This causes hypercalcemia. So even though the side effects are very similar in case of loop diuretics and thiazides, this is one of the main differences, that in loop diuretics we see hypocalcemia, whereas in thiazides we see hypercalcemia. All of these cause hypokalemia. This is because the increased sodium inside the tubules will finally get reabsorbed at the level of the collecting duct, where at the level of the principal cells in the collecting duct, we have the principal cells where there are two different channels, one for sodium reabsorption and one for potassium excretion. So if increased sodium is in the lumen, the body will try to conserve the sodium due to aldosterone action, and this increased sodium reabsorption will be associated with increased K plus excretion, resulting in hypokalemia. So hypokalemia will be seen with carbonic anhydrase inhibitors, loop diuretics, as well as with thiazides. Okay, so thiazides are useful in hypertension, heart failure, nephrolithiasis, nephrogenic diabetes insipidus, and adverse effects are same as loop diuretics: sulfonamide hypersensitivity, hypokalemia and alkalosis, hypomagnesemia, but hypercalcemia. It causes hypercalcemia. In addition to that, it may cause hyperglycemia and hyperlipidemia, and it is advised not to be given in young males because it can cause impotence. Now coming to the potassium sparing drugs. There are two types based on the mechanism of action. One is spironolactone and eplerenone, and then we have amiloride and triamterene. Spironolactone and eplerenone are aldosterone receptor antagonists. At the level of collecting duct and the distal convoluted tubule, we see that aldosterone acts at the level of principal cells. You can see it here in the diagram. And so if this is aldosterone, it binds with its receptor, with a specific mineralocorticoid receptor, and the aldosterone mineralocorticoid receptor acts at the level of the DNA, and what it finally does is that it tries to increase sodium reabsorption and cause increase potassium excretion. So this is inhibited by spironolactone and eplerenone. So they are useful in hyperaldosteronic states, and spironolactone also has anti-androgenic effects. So it is useful in female hirsutism. They are also useful in congestive heart failure, and they help to combat the hypokalemia, which is a side effect of the other diuretics. But the adverse effect is, if you take excess of it, it can cause hyperkalemia. Spironolactone has anti-androgen effects, and hence in males it can cause gynecomastia. It can also cause peptic ulcer, but eplerenone does not have anti-androgen effects. Amiloride and triamterene inhibit the epithelial sodium channels, so they help to conserve the potassium. And the amiloride, in addition to being used as an adjunct to hypokalemia causing diuretics, It is useful in lithium-induced nephrogenic diabetes insipidus and also in cystic fibrosis. Adverse effects are hyperkalemia and acidosis. So that finishes diuretics. Thanks for watching, and if you like the channel,